Hello everyone, welcome to Pediatrics by Dr. Anand. This is the Unacademy NEET PG platform, and today's topic of choice is nothing but a grand test. We have a grand test of image-based questions in pediatrics. I'll be asking you 100 questions. Each image portray some are of some syndromes, some are from the respiratory, cardio, endocrine, GIT, multiple systems we have covered. It's a grand test for the pediatrics, and this is the Unacademy NEET PG platform. And my name is Dr. Anand, and let's start the journey. So for all the newcomers in the amazing Unacademy, we have something known as Plus subscription and something known as Iconic subscription. In the Plus subscription, most importantly, you get to access from my all the live and recorded classes. At the same time, you get to study from the best educators all over the India, and also at the same time, you get to participate in various tests and quizzes. Okay, at the same time, you can watch me on your Android, on your laptop, and on your what do you call iOS phones also. And most importantly, this was Plus subscription. As far as Iconic subscription is concerned, most importantly, you get the Unacademy subscription, and also you get the Prep Ladder subscription in the Iconic subscription. All the clinical notes, video lectures, question bank, rapid revision, and treasure notes, everything you get in the Iconic subscription. And one is the Plus subscription. That's it. Like, this is the Plus subscription, this is the Iconic subscription. And if you want to take the pack, like being an MBBS student, I can understand it's financially becomes a little difficult to pick to take a big pack. So this is a small code. The code is Dr. Anand, so you can use this code to get some financial benefit out of the whole pack. And most importantly, we have a special class features also in the Unacademy itself. Like, this is the what you call YouTube channel, but in the Unacademy, the app itself, we have a very wonderful picture of making MCQs poll. You can ask me any doubt on the spot. You never miss my classes because all the lectures are recorded, and at the same time, you get all the written detailed PDF file of whatever I write the notes, and the notes are like everything. Notes are everything for us. And we have this very beautiful, updated, and highly effective question bank. At the same time, a beautiful congratulations to the NEET PG September 2021 students. And now on this chart, I want our new students, our Shubhangi, Ishita Srivastav, Sayani, Hamid, Deepak. We have so many thousands of students who are connected with me from the day one in the field of pediatrics, and I want their names to be there because hard work really pays off one day. Okay, and most importantly, we have this very beautiful free test rituals. If you're a newcomer, you can really give free test on the Wednesday, Friday, Saturday, Sunday. We have free test 9 a.m., 9 p.m. You can wonderfully give it and improve your knowledge. And most importantly, remember, yeah, are you understanding? So this is a very important part, and we have already made a batch of the Focus FMG 2022 and Target NEET PG 2022 batch, which is going houseful, which is going mind-blowing. And thank you so much for all the love and support. Now, today's chapter is a grand test. It's a grand test of the image-based questions of pediatrics. I'll be asking you a lot of questions from pertaining to image-based questions of pediatrics, and I want you all to give your best, shot. Okay, let's start. So it's a wonderful topic. See, it's divided into part 1, part 2, part 3. This is the part 1. The topic is grand test image based series of pediatrics. Question number 1: calculate the ponderal index. Calculate the ponderal index of a baby who is 1200 grams by weight and length of 42 centimeter. Calculate the ponderal index of a baby who is 1200 grams and length is 42 centimeter, and which type it fits into. It's a very important question. Yes. So what is this? How do you define ponderal index? Any random guesses? Very good. So ponderal index is nothing but any random guesses? Yes, very good. Weight in grams, weight in grams upon length in centimeter cube into 100. Weight in grams upon length in centimeter cube into 100. That is the formula of the ponderal index. Sir, why do you do ponderal index? Sir, to differentiate between symmetrical IUGR and asymmetrical IUGR. Sir, what is IUGR? Any random guesses? What is IUGR? IUGR is intrauterine growth restriction. Yes or no? Please remember, it is not retardation, it is restriction. Intrauterine growth restriction. Baby's growth is restricted intrauterine. Why? Because mother hemoglobin was 4. If there is a maternal anemia, if the mother HB is 4, how can she give the nutrients to the baby? So because of maternal anemia, because of some uteroplacental insufficiencies, yes or no? Because of some chromosomal abnormalities, genetic disorders, so like we have done a very beautiful 2 hours lecture on IUGR in our previous videos. If you're a newcomer, you have not watched the video, please go to the Unacademy app and our YouTube Unacademy channel where we have covered. It's free of cost. Please watch it. It will be really helpful for you. So the question number one is, calculate the ponderal index of a baby who is 1200 grams and length is 42 centimeter. Whenever I'm asking a question, I want you to take either you can pause the video and options are there. The 30 seconds you can take and answer me the video. Answer me the best answer. So the best answer for this question, anyone? Yes, the best answer for this question is nothing but the ponderal index is nothing but it coming for this baby is 1.6. And please remember, if the ponderal index is more than 2, then the baby is symmetrical IUGR. And if the ponderal index is less than 2, as in this case, the baby is asymmetrical IUGR. Asymmetrical IUGR. Can you tell me which one, like which IUGR has a bad prognosis and which one has a good prognosis? So most importantly, symmetrical IUGR. See, in symmetrical IUGR, remember, see, whatever I'm telling you, I'll be telling you associated points also, so that you can finish your whole syllabus. In the symmetrical IUGR, point number one, the insult is there from the beginning. The insult is there from the first semester. Whereas asymmetrical IUGR, the insert is in the late second trimester, like in the late trimester, second trimester, the insult is there. In the symmetrical IUGR, the insult is from the beginning, from the first trimester. So baby's head, baby's body, baby's liver, kidney, everything will be equally affected. That is known as symmetrical intrauterine growth restriction. And from the first trimester, if the insult has started, you can think of the causes could be some genetic defects. The causes could be some chromosomal disorders. The causes could be kind of a torch infection. Yes or no? These are the prime causes for the first trimester insult to the baby. Whereas in asymmetrical IUGR, the insult is there in the late first trimester or in the second trimester. So we all know that the development of the head, development of the brain, basically development of the brain happens in the first trimester. Development of the brain in the baby happens in the first trimester. As the baby is having insult, as the baby is having insult in the second trimester, so brain will be spared. Brain will be normal, but all of the body parts, the liver, kidney, thorax, abdomen, that will be shortened or that will be compromised. That is known as asymmetrical. That is known as asymmetrical intrauterine growth restriction. And what are the important causes of asymmetrical IUGR? The answer is maternal anemia. The answer could be uteroplacental insufficiency. Uteroplacental insufficiency could be maternal hypertension. Could be maternal hypertension. So all these causes are there in the what do you call in the asymmetrical IUGR. Are you understanding? Yes or no? I'm asking you a question and associated with finishing the other important pointers also. Okay, beautiful. Now come to the second question. The second question is, I am a newborn. I am a newborn with scalp swelling. It's a very good question. See, this is this image-based question, though it's like crazily awesome. Okay, let's read the question again. I am a newborn. Okay, I am a newborn who presented with scalp swelling, which became its maximum size by 24 hours of life, which became to its maximum size by 24 hours of life. Doctor said nothing to worry. He said it will take around 3 to 6 weeks to resolve. So what do you think I am suffering from? So straight away, it is a very neat and clean question. So what, like everything is there. Everything is there in the answer itself. The options are, what is this? Is it cephal hematoma, caput succedaneum, none of the above, or both? So anyone, any random guesses? What is this? This a swelling which come to its maximum size by 24 hours, and it takes around 3 to 6 weeks to resolve. So the answer is nothing but cephal hematoma. Cephal hematoma. Cephal hematoma, point number one, it is a swelling which takes around 24 hours to come to its maximum size, and it takes around 3 to 6 weeks to resolve. Very important. And whereas caput, what happens in caput? Can anyone tell me? The caput, it is a localized swelling. Caput is a localized. It is confined to the no, sorry, the caput swelling. Basically, remember, most importantly, it is because of the prolonged labor. The caput swelling is because of the prolonged labor. Point number one. And caput will be a diffuse swelling. If this is the scalp, then full diffuse swelling will be of the caput. In the caput, there is fluid accumulation. Why there is fluid accumulation? Because of the prolonged labor and something like that. So you get a fluid accumulation. Whereas hematoma, if this is the scalp, then hematoma is confined. Hematoma is confined to the suture line. Where you can see this picture itself, the hematoma is confined to one side, confined to the suture line. Whereas caput succedaneum, it is not confined to the suture line. It is not confined to the suture line. Yes or no? समझ में आ रहा नहीं आ रहा? Are you understanding? I want your best of the best vibration for this class, okay? Full positive vibes. I want no negative energy. Have a little smile. Watch me nicely. If you have read the whole pediatrics, watch me on 1x or 1.5x. You will enjoy the whole show. And if you're a newcomer, then watch me on the normal speed and just have a pen and a copy. Take a register and write pediatrics by Dr. Anand and start writing whatever points I'm telling. Okay. And also we have this very beautiful motivating quote. The motivating quote of today is push yourself. Push yourself because no one else is going to do it for you. If you think God will come from heaven and tell you, please study. No, nothing gonna happen like that. This is your life, your journey. Your life, your journey. So stop crying, stop cribbing, and start studying and start appreciating life. Instead of saying, मेरी जिंदगी में ही ऐसा क्यों हुआ? भगवान मुझसे क्या चाहता है? I am only sad, everyone is so happy. Stop doing that thing, you know. Be smart, have a vision, have a focus, have a goal, and work towards it. Stop being a cribber. No one is going to appreciate you, and no one has time also. Okay? So push yourself because no one else is for you. So yes, so the answer for the best answer for this question was cephal hematoma. The answer was cephal hematoma. Okay, very good, perfect. Next question. Okay, yeah. Now we are entering in syndromes, and I'm like, this is a very beautiful grand test series, and luckily you are fortunate you're watching it. Now we are coming to the on a moderate to severe variety of questions. I am a newborn baby born from a diabetic mother. I am a newborn baby born from a diabetic mother. I am having abdominal distension and inability to pass stool. A newborn baby who is born to is having born to a diabetic mother having abdominal distension and inability to pass stool. Whenever someone is having delayed passage of meconium or inability to pass stool, one of the differential always comes to our mind is nothing but Hirschsprung disease. Hirschsprung disease, for that we get a rectal biopsy to see the transition zone. So then the further question is, doctor thought I am having Hirschsprung disease. On further examination, it was found that my ganglion cells are appropriate in my rectum. Yeah, this is a good question. In Hirschsprung's disease, usually you get, what do you get? You get aganglionosis. Yes or not? Aganglionosis means ganglion cells are absent in one part. That's why the peristalsis is not happening. That's why my feces is getting stuck there. That's why I'm not passing stool. That's why I'm having abdominal distension. That's why I'm having all the issues. Yes or no? So these all things are there, right? So that's what on further that happens in Hirschsprung disease. But the question is, doctor thought I am having Hirschsprung disease. On further examination, it was found that my ganglion cells are appropriate in my rectum. I am still showing the signs of bowel obstruction. Doctor gave a conclusion that I may be suffering from a rare form of bowel obstruction, which is highly associated with maternal diabetes. So, what is the answer? Which is this rare form? See, this question is beautiful. Luckily, I made the question. Thank you. But this question is nice actually. This question is telling you toward the diagnosis. The last line it's saying doctor gave a conclusion that I may be suffering from a rare form of bowel obstruction which is associated with diabetes mellitus. Now, what is the answer for this? The rare form of bowel obstruction, which is basically what you called associated with maternal diabetes mellitus. Please remember is something known as left colon, something known as small left colon syndrome. Remember small left colon syndrome. Small left colon. Left colon means where exactly? At the post splenic flexure. Post splenic flexure, that part of the what you call left colon, it is very small in caliber. It is very small in size or caliber. The right colon and left colon, you have the splenic flexure and hepatic flexure. Yes or no? Do you remember this? Like this one, do you know, na? Okay, I'll make it for you. This is our big colon intestine. Yes or no? Here we have the liver, so this is the this hepatic flexure, and there we have the spleen. So this one is a splenic flexure, right? So post splenic flexure, that size is very small in caliber, and 40 to 50%, 40 to 50% of all cases of small left colon, for 40 to 50% of cases of small left colon, they are associated with diabetes mellitus. They are associated with diabetes mellitus. So 40 to 50% of all cases of small left colon, they are associated with diabetes mellitus. So the best answer for this question is nothing but our small left colon syndrome. And also at the same time, in the next exam, they can ask you how do you diagnose, what to do about it. See the question, no? Can you see the question? The baby is having abdominal distension. The baby is not able to pass stool. Because of this small left colon, the baby is not able to pass stool. So how will you diagnose or treat it? You will do the hyperosmotic contrast enema. You will do the, please write hyperosmotic. You will do the hyperosmotic contrast enema. You do the hyperosmotic contrast enema, you do, and the treatment is nothing but enema only. In this case, is of course, because the meconium, the stool is all stuck there because of small left colon. So you will do the enema, and hyperosmotic contrast enema is what we do. Done. Are you understanding? Yes or no? Please put a like button if you're able to understand. We are on the question number 3. It's a very beautiful platform, and very nicely we're covering the question. Let's just finish it off. Okay, let's just finish it off. Um, the topic of this series is grand test of images of pediatrics. Okay, question number 4. Very nice question. What can you see? I will not even tell you the this also. Option भी नहीं है मेरे पास. I don't have options. What is the answer for this question? What is the answer for this question? Anyone? What is it? Can we appreciate macroglossia? Yes or no? Can we appreciate macroglossia? Number 1. Can we appreciate a small head, something known as microcephaly? So macroglossia, microcephaly, and also what is what is this small ये क्या है कान के पीछे क्या दिखा रहे हैं ये behind the ear they are showing ear fissure, like they are in the ear lobe, there are fissures in the earlobe. So macroglossia, microcephaly, earlobe fissures, and also one extra hint I will tell you, hemihypertrophy of limbs. Hemihypertrophy of limbs. So what is the answer? The options are infant of diabetic mother, Beckwith-Weidman syndrome, and Prader-Willi syndrome, Angelman syndrome. The Beckwith-Weidman syndrome. Beckwith-Weidman syndrome is the best answer. Beckwith-Weidman syndrome has this only, macroglossia with microcephaly with hemihypertrophy of limbs, and these babies have more incidence of omphalocele. These babies have more incidence of umbilical hernia, or this baby has more incidence of Wilms tumor, yes or no? Yes or no? Wilms tumor is associated with 3 syndromes. Number 1 is Beckwith-Weidman syndrome, which we are studying. Number 2 is Denny-Drash syndrome. Denny-Drash syndrome. And number 3 is Vagar syndrome. Vagar syndrome. So Wilms tumor is associated with 3 syndromes: Beckwith-Weidman syndrome, Denny-Drash syndrome, and Vagar syndrome. This one is the case of Beckwith-Weidman syndrome. It's not infant of diabetic mother. In infant of diabetic mother, if the question had to come, the baby would have been a big baby, a heavy baby. Okay, and also very important, in infant of diabetic mother, even Beckwith-Weidman syndrome also, these babies are big only. Beckwith-Weidman syndrome babies also are a little big baby. But in infant of diabetic mother, then the mother will be hyperglycemic. The mother will be hyperglycemic, and the baby will be hypoglycemic. Very important. Okay, the mother will be hyperglycemic and baby will be hypoglycemic in a case of infant of diabetic mother. Done? Very good. Perfect. Very nice. Very good. Okay, now this is a good question. This overgrowth syndrome, same question, but like same pictures, same Beckwith-Weidman syndrome, but the question is changed. This overgrowth syndrome is caused by mutation in the chromosome what? Now, which chromosome basically has, do you see this overgrowth syndrome is caused by mutations in the chromosome dash? So options are A, B, C, D. Which is this syndrome? First of all, this syndrome is nothing but same our Beckwith-Weidman syndrome. And I told you in Beckwith-Weidman syndrome also the baby will be heavy. Okay, so overgrowth syndrome we call it. So which chromosome? Now this is the good question. Anyone? Question number 5. The best answer is D. chromosome 11p15.5. You have to learn this, that in Beckwith-Wiedemann syndrome, the mutation is in the chromosome 11p15.5. So 11, so I'll show you, yes. 11p15.5. This is our best answer for this question of the question number 5, that is Beckwith-Wiedemann syndrome. Okay, next question number 6. Question number 6 and 7 are a little tough. Which is the second most common syndromic form? Which is the second most common syndromic form of hyperinsulinemic hypoglycemia of infancy? Hyperinsulinemic hypoglycemia of infancy, because of the baby is having hypoglycemia because of increase insulin secretion. Hyperinsulinemic, okay, because more insulin will be there, so glucose will be get converted into glycogen. When more and more insulin is there, more and more insulin is there, glucose will get converted into glycogen and baby will have hypoglycemia. So the question is, which is the second most common syndromic form of hyperinsulinemic hypoglycemia of infancy? And the options are Kabuki syndrome, infant of diabetic mother, Beckwith-Wiedemann syndrome, and Prader-Willi syndrome. See, these four options are there, and imagine you don't know. Imagine मुझे पता ही नहीं है. I had no idea about the answer. If you have no idea about the answer, then there's an image also. I've kept the image for you. What is this image showing? What is the finding on this image? Can we appreciate again? Can we appreciate one side of the hemihypertrophy? Yes or no? Can we appreciate a hemihypertrophy of limbs? Hemihypertrophy. Can we see that this part is little bigger? Yes or no? And as this part is little bigger as compared to the other part. Yes or no? Yes. So hemihypertrophy. See that also, in that way also you can connect nicely. Hemihypertrophy of limbs is only and only seen in which condition in general? It is seen in Beckwith-Wiedemann syndrome. It is seen in Beckwith-Wiedemann syndrome. That is why the best answer is, in a case of the second most common syndromic form of hyperinsulinemic hypoglycemia of infancy, is nothing but Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. Okay, the best answer is Beckwith-Wiedemann syndrome. And next question is, which is the first most common cause of which is the first most common syndromic form of hyperinsulinemic hypoglycemia of infancy? It's a good question. Okay, which is the first most common syndromic form, and which is the second most common syndromic form of hyperinsulinemic hypoglycemia of infancy? The second most common is nothing but Beckwith-Wiedemann syndrome. The first most common syndromic form of hyperinsulinemic hypoglycemia of infancy. The picture, I have a picture. I'll show you this picture. It's a very beautiful picture. If you can appreciate, what are the findings? What are the findings in this picture? Any random guesses? Number one, what is this? ये क्या है इधर? What is this? Anyone? So this is nothing but prominent fingertip pads. I'll write for you. Prominent fingertip pads. Number one, very important. Now, very important, long palpebral fissure. Long palpebral, लंबी लंबी आंखें. So long palpebral fissure. I'll just change the pen. Long palpebral fissure. So what is this syndrome, sir, you're talking about? So with the in I'm see, every time I tell you, every syndrome has one specific peculiar point, and that is what we have to connect, and that is what we have to write in the exam to get the rank 1. We are only studying for rank 1, not for rank 2. So please remember, as I told you, hemihypertrophy is there in Beckwith-Wiedemann syndrome, whereas this one, this pad of fat, this prominent fingertip of fat is there in one syndrome, I'll tell you. Number two, the findings are, there's a prominent, what you call the palpebral fissure. Okay, and also this, can you see the lateral portion of the eyelids? Can we see the lateral portion of the eyelids? So there is eversion. Eversion. There is a eversion of lateral portion. There is eversion of lateral portion of lower eyelids. There is eversion of lateral portion of the lower eyelids, and that this is this wala part, this wala part. There is eversion of the lateral portion of the lower eyelids. So this is nothing but, the options are Kabuki syndrome, infant of diabetic mother, and Beckwith-Wiedemann syndrome. So the answer is nothing but Kabuki syndrome. This is nothing but Kabuki syndrome. Kabuki syndrome is the first most common. Kabuki syndrome is the first most common syndromic form of hyperinsulinemic hypoglycemia of infancy. It is the first most common syndromic form. Are you understanding? Yes or no, everyone? This is a very beautiful and important topic. Like, we are covering it very nicely. बहुत अच्छे से cover कर रहे हैं हम. ठीक है? चलो, very good. Question number 8. Okay, let me see if I have written any extra points of Kabuki syndrome. No, yeah, that is only the one. Question number 8. I am a newborn. I am a newborn, which is the best primary site. Which is the best primary site? My sample should be taken according to the image shown below. In a newborn, if you have to take a sample, which is the best site? If I show you this what you call soul of the baby, the options. The okay, so we have the options. Is it good to take sample from the point A? Or is it good to take the sample from the point B? Or the options are both are okay or none of the above. So what do you think? So please remember, it's a very simple question. Whenever you take a sample in a newborn, it's a very important image-based question. Whenever you take a sample in a newborn, always take from point A. Always on the lateral. This, you always prick the baby for hypoglycemia or for sugar checking over here. You never prick the point B. You never prick the point B because it can cause calcaneal injury or calcaneal fracture or calcaneum injury, or you poke the calcaneum. You don't poke the calcaneum, only side में थे. And please dear, never poke the fingers. ऐसे उंगली पकड़ के न्यूबॉर्न में बिल्कुल कभी नो, never take sample in newborn by pricking the finger. If you're an intern, if you're a JR, of course you'll do internship and JRship. Never you take a newborn's finger and put it. Finger is very 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 small, so don't touch the finger, please. You can touch the what you call the sole of the what you call the soles, and only the lateral parts, not the central part, to prevent the calcaneal. Question number 9. Question number 9. Which day stool sample is this in a newborn? Very good question. Very beautiful question. Which day stool sample is this in a newborn? Is it this sample? So what do you think, anyone? It's anyone put the answer in the comment section. What is this stool sample? Which day stool sample? The options are: is it on the day 1 and 2? Is it on the day 2 to 3, 6 to 8 and 8 to 10? कब ले कौन सा sample है ये बच्चे का? So is it day 1 and day 2 stool sample? I don't think so. Day 1 and day 2 stool sample is nothing but meconium. That is the first potty. The first potty of the baby is nothing but meconium, and that is usually black or blackish green in color. That is usually black or blackish green in color. That is the first and second day meconium baby stool color. Whereas this one, this is nothing but known as transition stool. This is nothing but known as transition stool. What is the color of the transition stool? The answer is the color of the transition stool is green color transition stool. And which day it comes usually? Roughly around day 2 onward, like day 3 and day 4. You can say that. Okay, the best answer is, yeah, day 2 and day 3, or day 2 to 4, something like that. Beginning 48 hours of life. Beginning 48 hours of life will be a meconium, blackish green in color. Next 48 hours of life will be a transition stool, which is nothing but green in color. And after that, day 4 or day 5 onwards, the baby will pass a golden yellow stool. The baby will pass a golden yellow stool. Yes or no? Are you understanding? Golden yellow stool. That is right, like day 6 onwards. So beginning 2 days meconium, next 2 days apna what you call till day 4 or day 5 is a green color transition stool. Day 5 onwards or day 6 onwards, it is our golden yellow stool. Golden yellow stool. Done? Very good. Identify the image. It's a good question. Let's see if you can answer this. Identify the image and tell us in which condition we have to give lifelong treatment using the device shown. Identify the image. So this device, what is this device? क्या कर रहे हैं बच्चे को? What is this device? This device is nothing but phototherapy. Yes or no? Phototherapy. Very good. So number one. Number two, tell us in which condition we have to give lifelong treatment using the device below. Options are Crigler-Najjar syndrome, Crigler-Najjar syndrome type 1, type 2, Dubin-Johnson syndrome, and Rotard syndrome. Dubin-Johnson syndrome and Rotard syndrome. So point number one, first we need to understand phototherapy. Phototherapy is useful for the unconjugate bilirubin. The unconjugate bilirubin cannot be excreted through the kidneys. Unconjugate bilirubin is very very dangerous as compared to the conjugate bilirubin. It is the unconjugate bilirubin is very very dangerous. Unconjugate bilirubin cannot be excreted through the kidneys. That is why unconjugate bilirubin I have to give phototherapy. I have to give phototherapy where the unconjugate bilirubin will get converted into lumirubin, and then it is get converted in the excreted from the body. Are you understanding? Yes or no? It's a rapid revision, so I'm having a speed of teaching. If you think the speed is too fast, you can put a 0.5x and nicely listen to me. ये आजकल तो बहुत it's a boon that our technology has reached such a beautiful scale that you can increase our speed, you can decrease my speed, you can listen to me in your own way any time. So I think it's good. Okay. So, what do you call it? What is this device? Phototherapy. What is the use? Phototherapy helps in converting the unconjugate bilirubin into lumirubin and then it gets excreted from the kidney. This mechanism is known as structural isomerization. This mechanism is known as structural isomerization. You know, right? There is the mechanism photoisomerization, structural isomerization, and photooxidation. The most important mechanism chiefly responsible for conversion in the phototherapy is nothing but structural isomerization. That is the first PG question. Second PG question was how does it work? It converts the bilirubin into lumirubin, and then it can be excreted by the kidneys because normally this unconjugated bilirubin cannot be get excreted from the kidneys. Number one. Now coming to the question is that in lifelong, like in which condition we have to give lifelong treatment using the device below. So let's see. So see, I told you in unconjugated bilirubin, this device is helpful. So we all know that at Dubin-Johnson and Rotard syndrome, it causes conjugated hyperbilirubinemia. Number one. Dubin Johnson and Rotar, they basically causes conjugate hyperbilirubinemia, whereas Crigler-Najjar syndrome type 1 and type 2 causes unconjugate hyperbilirubinemia. We all know that in Crigler-Najjar syndrome type 1 there is an absolute deficiency. There is an absolute deficiency of the UGT enzyme, uridyl glucuronide transferase. In Crigler-Najjar syndrome type 1 there is a absolute deficiency of the UGT enzyme, absolute deficiency. So when there is an absolute deficiency means the unconjugate bilirubin cannot be get converted into conjugate bilirubin. See, normally the unconjugate bilirubin get converted into conjugate bilirubin with the help of UGT enzyme, yes or no? So when the UGT enzyme is not there, that uridyl glucuronide transferase enzyme is not there, so unconjugate bilirubin cannot get converted into conjugate bilirubin. So in Crigler-Najjar syndrome type 1, there is an absolute deficiency. There is an absolute deficiency of the UGT enzyme. So unconjugate bil will not be able to get converted into conjugate bilirubin, leads to unconjugated hyperbilirubinemia. So in this case, okay, number one. Number two, very important, in Crigler-Najjar syndrome type 2. Yes, in Crigler-Najjar syndrome type 2, what happens? In the Crigler-Najjar syndrome type 2, there is 10 to 20%. There is 10 to 20% activity of the UGT enzyme. In Crigler-Najjar syndrome type 2, the UGT enzyme is there, but it is deficient, but it is still there. 10 to 20% it is there. And the drug of choice to increase the activity of the UGT enzyme is phenobarbital. Very important, phenobarbital is the drug of choice for the Crigler-Najjar syndrome type 2. Why not in type 1? Because type 1 there is a total absent of the UGT enzyme. No, in type 2 there is 10 to 20% activity of the UGT enzyme is there, and phenobarbital pushes more and increases the enzyme activity, so the conversion is more. Okay, so in which case you're going to give the phototherapy? So the best answer for this condition will be, of course, in Crigler-Najjar syndrome type 1, because in type 1 there's a total absent UGT enzyme, right? So when the UGT enzyme is absent, there will be unconjugated hyperbilirubinemia, and whenever there is an unconjugated hyperbilirubinemia, then of course phototherapy will be very, very, very helpful. Are you understanding? Yes or no? Everyone? 10 questions we have covered. We have 100 questions to go. So if you cover my grand test image series, like, awesome. Like, you will learn a lot, frankly speaking, because these notes I have made from Nelson, I have made from very standard books, and I have myself portrayed the MCQs, questions, got the images, collaborated, so that it becomes a image-based question also, it becomes a theory-based question also. It doesn't become the boring same theoretical question. I wanted little difference. That's why I'm sharing. Done. Hmm. Yes, very important. Image-based spotter. Image-based spotter. Most importantly, exactly. So before even showing you the MCQ, can anyone tell me what do you see? Like, see, don't have this habit. Don't you guys have a very bad habit of MC ऑप्शन दिखा दो बता देंगे. ऑप्शन दिखा दो हम अभी को एकदम बता देंगे. हेलो, ऑप्शन नहीं है मेरे पास. क्या करना है बताओ. So don't depend on the options. Can you tell me right now itself? Can we appreciate hyperpigmented knuckles? Yes or no? Can we appreciate hyperpigmented knuckles? That is the first point. Hyperpigmented knuckles. Right? Which is the most commonest cause? Anyone in pediatrics? A lot of babies we have with hyperpigmented knuckles. So have you heard of what you call megaloblastic anemia or vitamin B12 deficiency? So number one, vitamin B12 deficiency can cause hyperpigmented knuckles. There is a condition known as acanthosis nigricans. Acanthosis nigrans, you can say. Acanthosis nigrans, that is one condition, causes hyperpigmented knuckles. Even in a case of drug reaction also, some cases of drug reactions also can cause hyper, what you called pigmented knuckles. And dermatomyositis. Have you heard of dermatomyositis? These all are the conditions, even in Addison disease also. We had a patient in our Lady Harding also, we had a patient, and in our hospital also, of a case of Addison's disease. So I'll repeat again, what is this, sir? This is hyperpigmented knuckles. और हाँ exactly, दिख रहा है, वो तो साफ दिख रहा है. कहाँ मिलता है ये? Vitamin B12 deficiency, yes. Acanthosis nigrans, yes. Dermatomyositis, yes. Drug reaction, yes. And Addison's disease, yes. Let's see the options. The options are, yeah, acanthosis nigricans, vitamin B12 deficiencies, Addison disease, drug reaction, dermatomyositis, all of the above. So the answer is all of the above. Okay, and why do you get this black, this hyperpigmented knuckles? What do you think? What is the rationale? So there is increased melanin synthesis. Yes, naturally, whenever there is an increased melanin synthesis, you will see a hyperpigmented knuckle. Like what happened? Whenever there's a deficiency of vitamin B12, I told you, vitamin B12 deficiency causes this hyperpigmented knuckles. Whenever there's a deficiency of vitamin B12, there is decreased level. There will be decreased level of reduced glutathione. There will be a decreased level of reduced glutathione. Okay, and nothing but if there is a decreased level of glutathione, it will activate the tyrosinase. It will activates the tyrosinase. Okay, it will activate the tyrosinase. And what does tyrosinase does? Basically, tyrosinase leads to the transfer to melanosomes. Basically, tyrosinase helps in the melanin synthesis. So that is the reason you get hyperpigmented knuckles. I'll repeat again. Why do you see hyperpigmented knuckles? Because of melanin causes hyperpigmented knuckles. How? So whenever there's a decreased vitamin B12, it will cause decreased level of reduced glutathione, and whenever there's a glutathione reduced, it activates the tyrosinase, and tyrosinase basically helps in transfers to the melanosomes, or you can say helps in increase in melanin synthesis. That's it. Okay, done. Let's move to the next question. This is a very good question. For this, I would like to thank one of my junior, Dr. Nitin. He had given me this picture. Very thank you, bro. Nitin, you have really helped me a lot. And milky blood. It's a good question. Milky blood. In which condition do you see milky blood? The options are this question number 12. The options are A. L-captonuria, polycythemia, hypertriglyceridemia, or all of the above. Alkaptonuria, polycythemia, hypertriglyceridemia, and all of the above. So milky blood. Question 12. What do you think? Exactly. Whenever there is a high concentration, whenever there is a high concentration of lipids in the blood, whenever there is a high concentration of lipids in the blood, that nothing but known as hyperlipidemia or hypertriglyceridemia, and that gives a milky color blood, or a kind of a gives a milky color or milky appearance. Okay, I'll repeat again. Hypertriglyceridemia, when there is an increased concentration of lipids in the blood, that only will leads to a condition of hyperlipidemia or hypertriglyceridemia. Okay, good. Question 13. Question 13 was a recent FMG question. Question 13 was a recent FMG question. And it's a very important question. Again, I'll not show you the picture. Oh, sorry, I'll not show you the MCQs. Option नहीं दिखाने मैंने. What do you think is the answer? Look at the picture and tell what is the answer. So even my grandmother also can tell कि भाई this baby, this looks like a kind of anyone. Have you heard of slap cheek appearance? Yes or no? Slapped cheek appearance. Slapped cheek appearance. Exactly. So it's a case of slap cheek appearance. ठीक है, इसने थप्पड़ मारा जिसने, ऐसा वाला बच्चे का दाना लगता है. Slap cheek appearance. And where do you see slap cheek appearance? Okay, yeah, good question. Is it you do you see in fifth disease, sixth disease, fever with rash on day 7, fever with rash on day 1? Where do you see? Please remember, fifth disease is nothing but known as erythema infectiosum. Fifth disease is nothing but erythema infectiosum. which basically, with erythema infectiosum, yes, which gives the appearance of slap cheek appearance. Okay, whereas sixth disease is nothing but roseola infantum. Sixth disease is nothing but roseola infantum. And in roseola infantum, you see Nagayama spot. In roseola infantum, you see Nagayama spot. These two signs are important. In erythema infectiosum, you see slap cheek appearance, whereas in roseola infantum, you see Nagayama spot. Sir, what is Nagayama spot? Sir, कैसा दिखता है वो? Okay. So something known as fifth disease, something known as sixth disease. Fifth disease, the other name is erythema infectiosum, and nothing but you see a slab chick appearance. It is caused by DNA parvovirus B19. DNA parvovirus B19. Okay, that is the fifth disease. That is nothing but erythema infectiosum caused by DNA parvovirus B19. Sixth disease is known as roseola infantum. Sixth disease is known as roseola infantum. It caused by human herpes virus 6 more than 7. There are various strains and types of human herpes virus, but the human herpes virus type 6 is more common than the type 7. Nothing but roseola infantum is known as roseola infantum. And in roseola infantum, you see Nagayama spot. What is Nagayama spot? This is the next question. Can we see this micro ulcers? You can see this ulcers over the hard palate. Ulcers over the hard palate. This is full is the hard palate, and ulcers over the hard palate, like micro ulcers over the hard palate, is known as Nagayama spot. Is known as Nagayama spot. And where do you see? You see this is in roseola infantum. Roseola infantum. Sir, याद कैसे रहेगा? Sir, I get confused. Which one is roseola? So please remember, छक्का मारोगे तो गुलाब मिलेगा. छक्का मारोगे तो गुलाब मिलेगा. If you put a sixer, you'll get a rose. If you put a sixer, you'll get a rose. So sixer, sixth disease you see in roseola infantum, whereas slapstick appearance or fifth disease you see in erythema infectious. Done. Very good. Question 14 over already. That it is nothing but what do you call? Question number this 14 is this, you see Nagayama spot. So Nagayama spot you see in roseola infantum. Roseola infantum, and roseola infantum is known as sixth disease. Okay, done. Next, question number 15. Very easy question. What do you think, anyone? Question number 15. What do you think? Again, for every question, dear, it's a very wonderful series. Are you guys enjoying? Please put a like button if you are able to enjoy, understand the concept. It's very nice. Like, you are covering huge topic, like, frankly speaking. You're covering from respiratory, cardio, endocrine syndrome, everything, inborn errors of metabolism, everything you're covering, everything you're covering. Okay, very good. I want you to get the rank one. Rank one चाहिए मुझे, ठीक है? हाँ जी. Spotter. What is the spotter? Anyone? I'll not show you the option. ऐसे ही बता दो मुझे. So every time, thousand times I have told you that every syndrome has some peculiarity. Every syndrome has some specific strange thing specific for that syndrome. Can we see this white bunch of hairs? Yes or no? Can we see this white, you can say white forelock of hairs? Of hair. अच्छा hair बोलते हैं ना, hairs नहीं होता hair. White bunch of hair or white forelock of hair. Where do you see in this in which syndrome do you see in this one? Imagine, and also this baby will have heterochroma iridis. What is heterochroma iridis? Matlab, chroma means our eye, with this one iris, and heterochroma iridis means hetero means change in the color of the eye. One eye will be black, whereas the other eye will, the eye color will be of different iris. So iris color, the color part of the iris. So change, heterochroma iridis, change in the color of the eyes, number one. Number two, white bunch of hairs, number two, and hearing loss. They will have hearing loss. So what is the triad? What, like, this is the triad of which syndrome? The answer is our hostel ka warden. Remember our hostel ka warden. Imagine our hostel warden, known as Wardenberg syndrome. Wardenberg syndrome. Hostel ka warden, how is he? Hostel warden, he cannot hear anything. He has this white bunch of hairs, and he has the change in the color of the iris. So that is nothing but known. The spotter is nothing but, the options were Turner syndrome, Kabuki syndrome, Wardenberg syndrome, and Patau syndrome. The answer is Wardenberg syndrome. It's not a Turner syndrome because Turner syndrome is there in the female. A female with a webbed neck, with widely spaced nipples, a female with a webbed neck with widely spaced nipples and amenorrhea and all that, that is Turner syndrome. Kabuki syndrome we have already done. Remember Kabuki syndrome? You want to revise? Just see the picture of Kabuki. This one. This is the Kabuki syndrome, where number one, I saw this fingertips, pad of fat over the fingertips. I saw long palpebral fissure. I also saw a kind of an anti-mongoloid slant. Anti-mongoloid. See, mongoloid slant is upward slanting of eyeballs, whereas anti-mongoloid slant is lower slanting of eyeball. That also I saw. And also at the same time I saw the what do you call eversion, बाहर निकलती होती हैं, eversion of the lateral portion of the lower eyelid, seen in Kabuki syndrome. And Kabuki syndrome is nothing but it is the first most common syndromic form of hyperinsulinemic hypoglycemia of infancy. ठीक है, done. Done. कहाँ पे थे हम? Okay, let's do this. I something but Wardenburg syndrome. Done. Question 16, next Potter. Yeah. What is this question 16? Acha, one more thing I want to tell you. What is the gene mutation? What is the gene mutation you see in what you called our Wardenburg syndrome? Remember PAX3, PAX3, PAX3 gene mutation you see in Wardenburg syndrome. PAX3 gene mutation you see in Wardenburg syndrome. PAX3. It's an exam question. Okay. Very good. Chalo, next question. Question number 16. I think in 1 hour we can cover only 20 questions. Let's finish 20 questions in 1 hour. That will be the part 1 and then we have the part 2. Okay. It's the grand image based series of pediatrics. Grand test image series. Okay. So what is this syndrome? Again, I'll not tell you the options. क्या लग रहा है ये? कोई भी बता देगा ये syndrome. Even a 7th class baby also can tell this syndrome. Anyone? What is this syndrome? Any random guesses? Can we see little eyes a little up like that? Nothing but very important is nothing but anyone? Yes, nothing but mongoloid slant. Point number one is nothing but mongoloid. Mongoloid slant. That is the first point. Okay, these eyes are like that. No, that is known as mongoloid slant. Can we see a depressed nasal bridge? Yes or no? We can see a depressed nasal bridge. Yes or no? Can you see mouth wide open, tongue protruding out? So protruding tongue, mouth wide open, decrease IQ. Okay, all these, what are the syndrome? So the syndrome is nothing but the options are Turner syndrome, Kabuki syndrome, Waardenburg syndrome, and Down syndrome. The answer is Down syndrome. Okay, Down syndrome. Which is the most common? Which is the most common GI abnormality in Down syndrome? Anyone? Which is the most common gastrointestinal abnormality in Down syndrome? D for Down syndrome, D for duodenal atresia. D for duodenal atresia. The most common gastrointestinal issue in a case of Down syndrome is nothing but duodenal atresia. Duodenal atresia. Which is the most common congenital heart disease in Down syndrome? The most common congenital heart disease in Down syndrome is ASD, atrial septal defect, or ostium primum type of atrial septal defect. And in some books, they have written the most specific congenital heart is endocardial cushion defect. The most common is ostium primum type of ASD, and most specific is endocardial cushion defect. Okay. Question number 17. Rahul is 12 years old. Rahul is 12 years old. He's asking his expected height. Choose the best statement after seeing the image. Rahul is 12 years old. 12 years old. Okay, 12 years old. Okay, he's asking his expected height. So anyone, what is the formula for expected height? I told you. So 7x minus 5 by 2. Age in years, like x is age in years. 7 into 12 minus 5 by minus 5 by 2. So yes, 12 7 the 84. So 84 minus 5 roughly. So what do you think, anyone? How much it is coming? The options are expected height. Acha, so 7x minus 5 by 2. See, this 7x minus 5 by 2, what I told, this is for the expected weight. For the expected weight agar nikalna ho, they're asking the height. What is the formula for expected height? Age into 6 plus 77. Age into 6 plus 77. That's the formula for the expected height. Okay. Yeah, so the options are, choose the best option. Now see, this is the option with the image. What is this image, anyone? ये क्या है? क्या है ये? डंडे क्या खड़े हैं इतने बड़े बड़े? किसके हैं ये? क्या है ये? The answer is nothing but stadiometer. This is nothing but Stadiometer is nothing but stadiometer. Yes or no? Yeah, very good. So options are this instrument is stadiometer and Rahul expected height is 150 centimeter. Okay. Other option is the instrument is infantometer. Is this infantometer? No, I don't think so. The instrument name is stadiometer. Rahul expected height is 150 centimeter and the formula is age into 6 plus 77. Age into 6 plus 77. So what do you think? Which one is the better formulation of answer? So let's see. The better answer for this question will be nothing but A and C are right. Instrument is stadiometer, yes. Rahul expected height is 150, yes. And even C option is also right. Instrument name is stadiometer, yes. Rahul expected height is 150, yes. And the formula is age into 6 plus 77. Age into 6 plus 77. Okay, done. Very good. Perfect. Spotter. This is a good question. This is a good question. For many questions, I have made notes also because these are very nice questions. Hmm. Yeah, it's a very good question. What do you think, anyone? What is this? Yeah, yeah, 1, 2, 3, 4, 5, and these options are MSHD, LSHD, GSHD, and FSHD. What all these names? I don't know. Anyone? What is the name? Okay, so have you heard of facioscapular, facioscapular humeral dystrophy? So facioscapular humeral dystrophy, F is case of FSHD. What is this sign? What is this sign? Can we see? Can we hypothetically think that we are climbing on a hill? It's nothing but polyhill sign. It's nothing but polyhill sign. It's a polyhill sign. It's nothing but polyhill sign. What is this polyhill sign? Polyhill sign like this is nothing but polyhill sign. So polyhill sign you see in various conditions and like you see in FSHD, facioscapular humeral dystrophy. So basically, what is this point one? Point one will be there's a wasting of trapezius, wasting of trapezius muscle, number one. Number two, in what is this point number two? Point number two is superior angle of scapula. Point number two is superior angle of scapula. Okay, so wasting of trapezius, number one. Number two point is superior angle of scapula. What is this number three? Displaced AM joint. Displaced acromyoclavicular joint. Acromyoclavicular joint. That is point three. Which is point four? Point four is atrophied proximal deltoid. Atrophied proximal deltoid, and which is number 5. Number 5 is normal bulk of distal deltoid. Normal bulk of distal deltoid. Done. So these are the 5 important points of facioscapular humeral dystrophy. You see a polyhill sign. Polyhill sign number 1, there will be very important wasting of the trapezius. Number 2, I saw the superior angle of scapula. Number 3, I saw a displaced what you call acromyoclavicular joint. Number 4, I saw this atrophied proximal deltoid. And number 5, this is number 5, I saw the normal bulk of the distal deltoid. It's a polyhill sign seen in FSHD. FSHD is facioscapular humeral dystrophy. So 18, the best answer is our FSHD. Okay, and that's what, wait, let me go to the answer. Question number 19, choose the best statement. This only. Like this one, same thing only. This same thing, polyhill sign. Same polyhill sign. So the best answer is it's a polyhill sign seen in what you called FSHD, facioscapular humeral dystrophy. Okay. Okay, last question. Question 20. We'll do 2021 questions. We'll do in this first half of segment. This is the coronary artery angiogram of patient suffering from Kawasaki. This is the coronary angiogram of a patient suffering from Kawasaki to qualify as giant aneurysm. Qualify as giant aneurysm, internal diameter of the coronary artery should be more than what? This the diameter of this coronary artery to say it as a big giant aneurysm. How much should be the internal diameter of the coronary artery? The options are 6 mm, 7 mm, 8 mm, 9 mm. Anyone? What do you think? 6, 7, 8, 9. Very good. So remember in Kawasaki aneurysms, Kawasaki aneurysms, we have the small aneurysm, we have the medium aneurysms, and we have the giant aneurysms. Three aneurysms we have: small, medium, and giant, right? Thus, in the small aneurysm of Kawasaki, they're usually less than 5 millimeter in the internal diameter. They are usually less than 5 millimeter in the internal diameter, and medium Kawasaki aneurysm are usually 5 to 8 millimeter, and more than 8 millimeter. More than 8 millimeter will be the giant vertical aneurysms. So Kawasaki aneurysms, most importantly, remember they are small, medium, and giant. Small are less than 5 millimeter, medium are 5 to 8 millimeter, and to call it as a giant, it should be more than 8 millimeter. So that's the question only. To qualify as giant aneurysm, internal diameter of the coronary artery should be more than, the answer is 8 millimeter. 8 millimeter. Okay, who will tell me this Kawasaki? Is this small vessel vasculitis or a medium vessel vasculitis? Remember, right? We have small vessel vasculitis, we have medium vessel vasculitis, and we have large vessel. We have large vessel vasculitis. Yes or no? So, okay, who will tell me the examples? Yes, the examples of large vessel vasculitis are Takayasu arteritis, Takayasu arteritis, and also the giant cell, giant cell arteritis. Takayasu arteritis and giant cell arteritis is nothing but about large vessel vasculitis. The examples of medium vessel vasculitis, anyone? What are the examples of medium vessel vasculitis? So medium vessel vasculitis are basically two, Kawasaki and Pan. Kawasaki and Pan are medium vessel vasculitis. What is Pan, anyone? Polyarteritis nodosa. Polyarteritis nodosa is medium vessel vasculitis. And what about small vessel vasculitis, anyone? Small vessel vasculitis. Small vessel बहुत सारे होते हैं. Small vessel vasculitis are, okay, I'll tell you, they are Wagner's granulomatosis. Wagner's granulomatosis, number one. Church-Strauss syndrome. Church-Strauss syndrome. HSP. What is HSP? Hinong Pionlin purpura. So all these are the examples of small vessel vasculitis. Okay, so small vessel vasculitis are Church-Strauss syndrome, Wagner's granulomatosis, HSP, many things. And whereas medium vessel vasculitis are Kawasaki disease and polyarteritis nodosa. Large vessel vasculitis are Takayasu arteritis and giant cell arteritis. Takayasu arteritis and giant cell arteritis. Okay, and okay, can anyone tell me, where do you see strawberry tongue? Where do you see strawberry tongue? Any random guesses? So please remember, three strawberries we need to understand. We have strawberry tongue, we have strawberry vagina, we have strawberry gingiva. Okay. So where do you see strawberry tongue? You see strawberry tongue in a case of Kawasaki. In a case of Kawasaki disease, we see strawberry tongue, and we also see strawberry tongue in scarlet fever. Strawberry followed by whitish. So in Kawasaki disease and scarlet fever, you see strawberry tongue. It has been an exam question. Strawberry vagina question came in last year NEET PG exam. Strawberry vagina, it is seen in trichomoniasis. Trichomoniasis is nothing but, you see, strawberry vagina. Where do you see strawberry gingiva? Strawberry gingiva is seen in Wagner's granulomatosis. यहीं पर ही लिखा है. Remember, gingiva छोटे होते हैं. So छोटे means small. Small vessel vasculitis is Wagner's granulomatosis. Gingiva are small, so small vessel vasculitis, Wagner's granulomatosis. So strawberry gingiva you see in Wagner's granulomatosis, strawberry vagina you see in trichomoniasis, strawberry tongue you see in Kawasaki and scarlet fever, and these are the important points. Okay, and that's what. And medium vessel vasculitis, usually it causes intermittent claudication. Large vessel basically are the aortic problems, aortic aneurysms, like that. Okay, so large vessel, medium vessel, small vessel. Large vessel, medium vessel, and small vessel. This is the important part that finishes the first half of the grand test images of pediatrics. This is the first half which will be uploaded everywhere, and very important. We are covering like huge segments. We are covering every corner of pediatrics, and we are trying to cover the whole syllabus. And if you can see, we have done good questions. Which all topics we have covered? And we have covered about this what you called large vessel, medium vessel vasculitis. Then one very important questions of polyhill sign in facioscapular humeral dystrophy. This is very important. Okay, this polyhill sign is very important. Then also we covered very important infantometer and stadiometer, and the formula. Remember the formula, okay? For height, For calculating the height, the formula is only one, age into 6 plus 77. For weight, for so 6 year to 12 years baby, to know the expected weight, we use something known as 7 into age in years minus 5 by 2. 7 into age in years minus 5 by 2. Okay, then also we studied about the Down syndrome, and remember in Down syndrome the IQ is delayed. There is only one syndrome where the IQ is not delayed. We all know that. That is Turner syndrome. A female with a webbed neck, with widely spaced nipples and amenorrhea and all those things, they cannot have babies. They will have streaking of ovaries and all that. So those babies, like, that is nothing but Turner syndrome. In Turner syndrome, IQ is normal. IQ is normal. And most common congenital heart in Turner syndrome is bicuspid aortic valve, and most common cause of death in Turner syndrome is coarctation of aorta. That also we have covered multiple times. Then also we finished something about our hostel ka warden. Our hostel ka warden, he little he usse सुनाई नहीं देगा. He'll have hearing issues. Number two, he'll have white bunch of hair in the front, white bunch of hairs, and also he will have eyes color change, change in heterochroma iridis. This my color is like black eye, and then here is the blue color eye, like that. And very important, the gene mutation in Waardenburg syndrome is PAX3. Then also we covered something about Nagayama spot, which is seen in what you called in Roseola infantum, which is sixth disease. And then we saw the slap cheek appearance, which has already been just now, few days back only, for FMG question it had come. So slap cheek appearance you see in erythema infectiosum. Okay, and erythema infectiosum is known as fifth disease, whereas the Roseola infantum, where you see Nagayama spot, that is sixth disease. याद कैसे रहेगा? छक्का मारेंगे तो गुलाब मिलेगा, छक्का मारेंगे तो गुलाब मिलेगा. If you put a sixer, you get a rose. So sixth disease is nothing but roseola infantum. And remember, this sixth disease, that doesn't mean that fever with rash on day 6. Fever with rashes on day 6 has separate entity. This sixth disease is just a name. Sixth disease, fifth disease. That's all you should know. Then also we covered very importantly our milky blood we see in hypertriglyceridemia. Then also we covered very beautifully hyperpigmented knuckles seen in vitamin B12 deficiency, acanthosis nigrans, hyper, drug reactions, Addison's disease, dermatomyositis, and all those conditions. Okay, that's important. And please remember that what you called lifelong phototherapy you will give in Crigler-Najjar syndrome type 2. In type 1, I mean. In type 1, you know that, right? In Crigler-Najjar syndrome type 1, there is cancelled UGT. Like, there is no total deficient of the UGT enzyme. That is why I have to give lifelong phototherapy. Whereas in type 2, I will give phenobarbital as the drug of choice to increase my activity of the UGT enzyme, because in type 2, 10 to 20%, 10 to 20% activity of the UGT enzyme is there. Okay, then we also covered body transition stool. The color of the transition stool is green. The color of the meconium is black. A healthy baby stool is nothing but golden yellow stool. And then very importantly, the side, we always prick on the sides of the newborn. Never prick in the center. Never. Why? Because calcaneum fracture या calcaneum injury जो है हो सकता. We read about Kabuki syndrome. Then also we read about Beckwith-Weidman syndrome. Then also we read very importantly about cephalhematoma and caput succedaneum. Then also we read about the Ponderal Index, which is nothing but weight in grams upon height in centimeter cube into 100. That differentiates, like, Ponderal Index is used to differentiate symmetrical and asymmetrical IVGR. And always remember, yes, that's what. So less than 2 or more than 2, like that you have to remember. This is important. This has come in exams also, like symmetrical and asymmetrical IUGR. And one more thing I want to tell you. Yeah, yeah. More than 2 is symmetrical IUGR, and less than 2 is asymmetrical IUGR. Okay, that's it. Thank you so much. Thank you so much for this wonderful webinar. Thank you. This is the only 20 questions we could cover in 1 hour. And now the part 2 is going to come soon. Stay in touch. Stay in touch in the Unacademy app, and stay in touch with the new notifications from on the YouTube Unacademy channel also. And before leaving, we have this amazing motivating quote which says, "Push yourself. Push yourself, because no one else is going to do it for you. Push yourself. You have to be happy by yourself. No, God is not coming down and help you in studies. No, you have to study on your own. You have to be happy on your own. ऊपर से परमात्मा ऐसे प्रकट नहीं होने वाले, इतना टाइम किसी के पास नहीं है. So push yourself, because no one else is going to do it for you. So thank you so much and have a wonderful evening.